that PE is the leading cause of preventable hospital death. We probably miss this diagnosis more than we think we do and more than we ought to. And I think one particularly life-saving mantra to utter in the ICU is, could this be a PE? Something that I ask myself a lot. Because even though sometimes PE is a very obvious diagnosis, it can also be fairly subtle, especially in somebody who's got other disease and PE on top of it, where sometimes it's hard to differentiate. Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm your co-host, Dr. Nick Mark. We absolutely cannot wait to share with you what is certain to be a haymaker of an episode for us. We're going to talk about pulmonary embolism, or PE. What do you think, Cyrus? Will this be one for the ages?
Nick, it's good to be back on air with you. And of course, I'm also stoked to talk about PE. I think this one's going to be a winner. I think our audience is going to love it. And I think this is going to be one that gets revisited time and time again. You know, PE is a topic that's near and dear to my heart. I really love talking about it. I love talking about the right heart. The thing for me is I just love talking to students and residents about PE, especially because the physiology is so rich, the pathophysiology is so interesting. And really, sick patients with PE are truly sick patients. And so our goal here is to make sure that listeners get a great understanding of what it means to have a pulmonary embolism for their patients and how best to approach them.
Yeah, I second that. PE is a really fascinating disease. I mean, it's one of these diseases that can range in severity from something you discover incidentally, and you're almost like, do we even need to treat this as an outpatient, to somebody who could literally be the sickest person in your ICU. It's also dynamic. So somebody can come in looking great and suddenly become super sick. So there's a lot of clinical challenge wrapped up in that. There's also a fair amount of diagnostic challenge. As we'll talk about, PE is an easy diagnosis to miss, and it's something that we have to use all of our clinical toolkit, point of care ultrasound, physical exam, imaging, in order to make a diagnosis. And then finally, treating PE is complex. It requires a lot of my favorite things in the ICU. Again, point of care ultrasound, an understanding of physiology, titrating various interventions, and then finally a multidisciplinary approach. And it's a really fun and gratifying disease to treat, because you can really make a big difference in somebody where they go from being on death's door to walking out of the hospital, potentially in just a few days. With any big topic like this, we're obviously going to need a roadmap.
Nick, that's right. This is a huge topic, and we definitely want to make sure that roadmap is effective and helpful for our listeners. And so, we kind of decided, if we're going to do this right, it's going to need to be a two-parter. And so we're going to take this opportunity to focus on part one, which is going to be a practical approach to PE by laying down the foundation of physiology and pathophysiology. And then in part two, we're going to jump into a case and advance that case along, allowing us to build on those foundational elements, but also talk about some of the all-important interventions one by one and some of the evidence that supports those interventions.
By the time we're done, we hope that these 2 episodes will provide a roadmap that will serve you the next time you're taking care of a sick person with PE. We've got a lot to cover, so let's jump into it. First thing we should probably talk about is just how common PE is. PE is diagnosed almost every day in the emergency department, in every emergency department. We frequently see these patients come into the hospital, and in many cases, they're just sent home on oral anticoagulation. Only a subset of them really need to be admitted to the hospital. There was a study in Chest in 2019 that found that there were 2 million admissions for PE over a 15-year period, which works out to be greater than 100,000 admissions per year, which is a lot of patients. As you might expect, these patients tend to be older. They tend to have more comorbidities, particularly cancer. But PE is really striking because it's a disease that can affect almost anyone. It's not uncommon to see a young, previously healthy person, who has like an injury or a long plane ride, who comes in with a PE. So it's really a disease where almost anyone can get it, and it's important to keep in your mind. In terms of diagnosing PE, which is really not going to be the focus of this episode, there are a lot of tools that people can use to try to predict if they have it or not, and sort of guide the workup. One thing we probably should talk about, though, in terms of risk prediction in PE, is talking about some of the scoring systems that exist once you've made a diagnosis of PE, and kind of how you can risk stratify people. And I'll tell you, in my shop, where we have a dedicated PE response team, we use two of these scoring systems. First, we use the BOVA score as a means to decide whether or not to activate the team, sort of as a triage step. And then once we've decided to activate, we use the simplified PESI score, or SPESI, as a means to risk stratify patients into categories like high risk, intermediate risk, or low risk.
So, thanks, Nick, for sharing some of that. I think those are all very important points. And so, we'll, the nomenclature in the United States is often massive versus submassive, which I don't particularly like. I don't think it's as helpful as what the European Society for Cardiology offers us in regards to their criteria and their stratification, which is again that intermediate high versus intermediate low versus high risk. And I think that we're going to talk a little bit about what that means here in a second, but I think that that is a little bit more of a granular and a little bit more of a helpful way to view these patients. So, like I said, the European Society for Cardiology, they use these terms, and specifically when we talk about our intermediate high risk patients, we're talking about the patients that have a high PESI or SPESI score with evidence of RV strain and positive cardiac biomarkers. So those would be your intermediate high risk. And whether that's troponin or BNP, it doesn't really matter. But the key there is that they have evidence of RV strain and positive biomarkers. Now, if a patient presents like that and also is in shock, that would be considered a high risk patient. And so that's really where the rubber meets the road. And I'll also say that in your intermediate low risk patient, well, that might be a patient that has a higher PESI or SPESI score with either evidence of RV strain or cardiac biomarkers that are positive.
Yeah, I think that's a great summary. I think the sort of, more traditional way of risk stratifying was to say massive PE, somebody is in shock, versus submassive PE, somebody's got RV dysfunction. The European Society of Cardiology's approach is more granular and I think more useful because it helps us figure out, of the people who are not in shock, who is the highest risk and who therefore probably merits more aggressive treatment to prevent them from going into shock. And I think that's a key distinction.
Beautiful.
Now
Yeah.
that we've framed our discussion a little bit, why don't we do a deep dive into the pathophysiology of PE? So Cyrus, you want to kick us off here? This is a topic we both love.
Absolutely. So, pathophysiology really is fascinating. And from the get go, as you sort of alluded to earlier, it's interesting to think that PE patients really do run the spectrum from relatively asymptomatic who could be safely discharged all the way up to those that are presenting in cardiac arrest or in cardiogenic shock. And so the real unifying feature of the people who are sick from PE, and that's what we're going to focus on. We're going to focus on those patients that we might see in an intensive care unit. The unifying feature, and what really kind of suggests high risk or higher risk, I should say, it all boils down to the effect of clot on the right ventricle, the effect of that increase in pulmonary vascular resistance on the right ventricle, and this idea of an RV death spiral.
And I think that's really one of the key points. Often people will look at radiographic findings like clot burden and confuse that with severity. And it turns out there's actually a fair amount of discrepancy between how much clot you have on imaging and how much RV dysfunction you have. And that probably reflects the fact that some people are able to tolerate an increase in pulmonary vascular resistance, or PVR, better than others. So even though clot burden is an important characteristic, I actually care much more about the effect that it's having on the person's hemodynamics and specifically RV function.
Nick, thank you for highlighting that point. A lot of times in medicine, size does matter, but in this case, size doesn't necessarily matter. You can have patients with a significant clot burden on imaging that aren't as sick as those that might have a lower clot burden. And so I think it's important to remember that and important to remind, especially, learners of that reality.
One trick question that I like to ask learners, in fact, is what finding on a CT angiogram of the chest is the best predictor of mortality in PE. And it's a trick question because the feature which is most predictive is actually if you see reflux of contrast into the IVC. because that's what that's telling you is it's telling you that you inject contrast into the SVC and the right heart is struggling to move that contrast forward. So it actually moves back into the IVC. And so good trick question if you have a round with me, but also, good way to remember that it's the physiologic effect of the clot that really matters.
Excellent point. Yeah, it's definitely a great takeaway for our listeners. So, moving on from that, when we do think about sick PE patients, they often do present with hypoxemia. And so I've had nurses and learners say like, oh, PE patients die because they become hypoxic. And well, the reality is that it's a combination of physical clot burden and the associated inflammatory response that leads to RV failure, eventually LV failure, and cardiogenic shock with a hint of obstructive shock. That's truly what causes these patients to die if they're not intervened upon properly and appropriately. So let's unpack this a little bit. And I'll start by saying, the development of PE, whether that's clot in situ or it's a DVT that embolizes to the pulmonary vasculature, can cause a significant rise in PVR, or pulmonary vascular resistance. And another way to look at that is it's causing an increase in the afterload that the RV is susceptible to and having to pump against.
Exactly. So if you get a large clot that goes to your pulmonary vasculature, it will reduce the cross-sectional area of vessels for blood to go to. And that means that the RV is having to pump the same volume of blood into a smaller area. And thus pressure has to rise, and thus the RV has to work harder. But unlike the LV, which is thick and muscular and good at dealing with high afterload, the RV is ill-equipped to do this. And when the RV is pumping against a lot of resistance, first of all, the RV can fail. It can not achieve that. And secondarily, the RV gets bigger. You get pressure volume overload, and that expansion of the RV can actually start to impinge on the LV.
That's right. A great discussion there, Nick. And, really in the appropriate setting, as we sort of alluded to already, these patients can get very sick very quickly. And it's in large part because of the interaction between the RV and the LV, and the fact that the RV just cannot tolerate afterload in the way that the LV can. And so essentially the increased RV afterload forces the RV to work harder. And just like any other muscle, that means there's going to be an increase in oxygen demand. The increase in oxygen demand begets RV ischemia, which results in decreased RV contractility and thus decreased RV output.
Right. That's the essence of this death spiral of the RV right there. One saying that I'm stealing from you, Cyrus, is that you could think about the RV and LV as being both in series and in parallel. That is to say that the RV output feeds into the LV, so they're in series in that sense. And what that means is that if RV output falls because it can't pump against a high pulmonary vascular resistance, that means that the preload to the LV is also going to fall. So you're going to get a systemic decrease in cardiac output. But there's another sense, too, where the RV and the LV are in parallel. And what I mean by this is that there's an intraventricular septum between them. So when RV pressure volume overload occurs, it pushes that septum over into the LV. So as the RV gets bigger, implicitly the LV stroke volume falls. And this is another big thing that can both cause LV outflow tract obstruction if the septum pushes really far over, and it also just decrease the LV stroke volume, which is going to contribute to shock as well. And so remember that the RV death spiral can quickly become an LV death spiral as well.
I love that. I love that that description and that explanation, Nick. I think it's a perfect way of sort of encapsulating what's really happening both in the RV and in the LV. And it really underlines the fact that we're talking about, in the worst cases anyway, a combination of obstructive and cardiogenic shock, whereby RV failure begets LV failure, which further begets RV failure as coronary artery perfusion pressures tank and the already taxed RV receives less and less oxygenated blood. And so if that process is left unchecked, these patients are going to develop refractory shock and they're going to die. And so this is why diagnosis and appropriate management of PE is so important. And, it's also important to understand the elements of pathophysiology here, not just the end state. And because understanding the elements of pathophysiology will allow us to appreciate the nuances of the condition and allow us to make mindful management decisions every step of the way. For example, PE is not generally a volume down state. It's a state that can be characterized by hypotension and a state that, as we discussed, can result in shock. But that shock is not necessarily a function of hypovolemia. And often it's not, in fact, a function of hypovolemia. And so giving these patients volume because their blood pressure is low is often not the right answer. And in fact, putting in that bolus of fluid can strain an already strained RV. That RV is already kind of undergoing a stress test, if you will. And so you might be thinking you're giving fluids to support the blood pressure, but that bolus of fluids may be more of a death knell than a panacea.
Absolutely. Yeah. It's a good reminder not to use fluids reflexively, but to think about the physiology that you're treating and to act accordingly. One thing that we should also talk about is hypoxemia in the setting of acute PE. So I find that people are often confused about why PE causes hypoxemia. Sometimes people erroneously think that PE causes shunt. This is actually not true. The reason for hypoxemia in PE is VQ mismatch.
Nick, do you mind kind of clarifying that for our audience?
Yeah, absolutely. So, um, recall that normally some parts of the lung are better ventilated and some parts are less well, and those parts are better perfused. And then there are parts that are less well ventilated and those parts are less well perfused. We call this process VQ matching, which under normal circumstances works pretty well. In acute PE, however, if you have a thrombus which is blocking a big chunk of the lung vasculature, this increases the pressure in all the rest of the vasculature. And this can cause blood flow to redistribute so that some of those poorly ventilated areas are now getting more blood flow. And so we call this VQ mismatch. And this is why people with PE often become hypoxemic. It's worth remembering that this is why people with PE generally respond pretty well to oxygen, right? Because if you take those poorly ventilated lung segments and you put a bunch of extra O2 in there, you'll raise their saturation accordingly. Another thing that we should talk about from a pulmonary physiology perspective is what happens in terms of dead space, right? And so remember that if you have a big chunk of your lung which is no longer getting blood flow, now that chunk of your lung can't excrete carbon dioxide. And so what you'll see here is you'll see somebody who's breathing a lot with a normal CO2 or maybe even a high CO2. Every time I see somebody with a high PCO2 despite hyperventilation, I always think about dead space. And it's something that should trigger you to think, high dead space, could this be a PE? So now that we understand why people with a PE develop hypoxemia, we can think about what effects it has and why that's so important. So remember that your pulmonary vasculature is designed to limit blood flow to areas that aren't getting very much oxygen, right? We call this hypoxic pulmonary vasoconstriction. The problem is that if the blood itself is hypoxic, it's going to cause vasoconstriction everywhere. And thus, hypoxemia will lead to vasoconstriction all through the lungs, which causes increased pulmonary vascular resistance. So it's really important to treat hypoxemia in patients with PE because hypoxemia is a big contributor to pulmonary hypertension. Tying this back to what we were saying a moment ago about the RV death spiral, realize that if somebody's RV is failing, their RV cardiac output is falling, and they're doing a worse job of getting oxygen from the lungs, and this is going to cause them to be more hypoxic, and that's going to cause the pulmonary vascular resistance to increase, which is going to cause them to have worse RV dysfunction. So one intervention that we can apply is really simple, just giving them supplemental oxygen. One other thing that we should talk about while we're discussing factors that affect pulmonary vascular resistance is remember that hypoxemia is not the only thing which increases PVR. Hypercarbia and acidosis both do as well. And so later on, when we talk about treatment, we'll talk about why it's important to be really proactive about treating hypercarbia and acidosis to prevent those from causing more RV death spiral.
Nick, that was a lot of high yield information. I want to summarize it really quickly for our audience. So basically, unless someone has a PFO, what we're likely talking about when it comes to hypoxemia in these patients is VQ mismatch. Almost certainly that's the case. And so providing those folks with supplemental oxygen is going to be the right move. Not only is it going to help them obviously improve their oxygen delivery by way of giving them more oxygen, but as you astutely pointed out, Nick, it's going to help with some of that pulmonary vascular resistance that they're contending with as well, because we know that oxygen is a pulmonary vasodilator. It's sort of like the poor man's pulmonary vasodilator. We're going to talk about some other options that one can utilize a little bit later in the episode, but certainly first and foremost, that's what you're going to want to do. And then I also appreciate, Nick, that you mentioned the importance of mitigating hypercapnia and acidosis, as those are going to work counter to what you're trying to do as far as the RV is concerned. And so, having discussed that, I think those are some really important points. We haven't spent a whole lot of time talking about diagnosis of PE, and I don't really want to belabor this point too much, but could we at least share, perhaps, Nick, some of the important pearls that we have learned along the ways that might help our audience out?
Yeah, so I think we would be doing a disservice if we didn't talk a little bit about diagnosis. And I think a couple of key points to emphasize. First off, fans of the show who listened to Matt Rendo talk a couple weeks ago about DVT prophylaxis might remember one really important fact that he mentioned, which is that PE is the leading cause of preventable hospital death. And we probably miss this diagnosis more than we think we do and more than we ought to. And I think one particularly life-saving mantra to utter in the ICU is, could this be a PE? Something that I ask myself a lot. Because even though sometimes PE is a very obvious diagnosis, it can also be fairly subtle, especially in somebody who's got other disease and PE on top of it, where sometimes it's hard to differentiate.
Yeah, that's excellent.
I think, classically we're used to PE presenting with sudden onset tachycardia, chest pain, hypoxemia, progressing maybe to shock. But remember that many of our patients are already in shock, so you have to be suspicious. Another thing to remember is that patients who are beta blocked may not exhibit tachycardia. And so, none of the findings here, other than imaging, is really super sensitive and specific.
Nick, I'm glad you brought that up, because I think we do classically think of the tachycardic patient with chest pain and hypoxemia as being the PE patient. But there are a lot of reasons why, whether it be cryptic shock, like the shirt that you're wearing suggests.
Future
There you
swag.
go, showing it off. Yeah, whether it be cryptic shock, beta blockade, or what have you, you can't always just hang your hat on that. It is good for folks to be familiar with the common findings. So, of course, tachycardia, chest pain, hypoxemia that leads to shock and altered mental status. That's clearly worrisome for PE when it does manifest. We know that the most common finding is going to be sinus tachycardia in these folks. It's not the classic like S1Q3 inverted T3 that we often get quizzed on, but both of those things can be found. And like you said, Nick, you may not see that tachycardia at all. You may see a normal sinus rhythm, either just because you do or because the patient's beta blocked. And then some other findings on the EKG might include incomplete or complete right bundle branch block. You might see a large R wave in lead V1. You could also see right axis deviation. And then you may also see T wave inversions, and those would likely be in the inferior leads, so 2, 3, and AVF, or you might see them kind of on the right-sided precordial leads as well. Nick, what about some imaging findings that you want to discuss?
Yeah, and I would just emphasize that incomplete right bundle branch block, large R wave in V1, right axis deviation, those are all signs of RV strain. Those are just electrical signs that RV is distended and maybe not working so well. So good to think about those not as sort of random things, but part of a spectrum of RV strain on the EKG. So talking about imaging, right? There are a whole bunch of these eponymous signs on a chest X-ray. You will look brilliant if you can name them all once you know the diagnosis of PE. But unfortunately, most of these are not super useful prospectively. We could talk about Fleischner's sign, Hampton's hump, Westermarck's sign. These are all things that you can see on a chest X-ray that you should know what they are. But unfortunately, they're things that are really very useful retrospectively and not super useful prospectively. Just to give sort of a high-level summary of the radiograph findings, sometimes you'll see that the pulmonary vessels themselves are enlarged. That's like Fleischner's sign. Sometimes you'll see that the pulmonary vessels have a cutoff. That's like a knuckle sign. And sometimes you'll see that an area of lung is either too lucent because it's not getting enough blood flow. That's Westermarck's sign of oligemia. Or you'll see the opposite, which is that an area of lung has been without blood flow for a while, and now it's actually infarcting, and it becomes opacified. That's called Hampton's hump, which is classically sort of a peripheral wedge-shaped opacity. These are great. Unfortunately, none is sensitive, none is specific. And so, you're probably better off if you're hemming and hawing about that chest X-ray. You're probably better off getting a better imaging modality like ultrasound, CTA, etc.
And Nick, but just before you jump into ultrasound, just to highlight one of the points you made, as I was preparing for this episode, I did some digging and came across this study from 1993 looking at Westermarck sign, where they cited a specificity of 92% and an absolutely pathetic sensitivity of 11%. So that's kind of the quality we're talking about in some of these cases, Nick.
Yeah, exactly. That illustrates it perfectly. So, what's our alternative? What's a better test? Well, point of care ultrasound is, I mean, this wouldn't be an episode of Critical Care Time if we didn't extol the benefits of point of care ultrasound, first of all. But I think it's particularly useful here. It's useful in a couple of different ways. One, if you scan the legs and you find a DVT, well, you've pretty much made your diagnosis of VTE right there and the therapeutic implications of it. So that's useful. It's also a great way to assess the RV. And there's a couple of different tests that you can do here. The first is just sort of the eyeball test. You look at the right ventricle, and does it look normal? Does it look big and barely moving? Right. And that's a fine place to start. It's probably okay as a first pass, but probably not really sufficient for more advanced medical decision making. So there's a couple more advanced maneuvers we can do. And the one that we'll have in the infographic on this is something called TAPSE, or tricuspid annular plane systolic excursion. And the idea here is we're measuring how hard the RV is squeezing by measuring how the tricuspid annulus is moving up and down. And if you can picture this, remember that the LV sort of squeezes from the sides in, it's sort of squeezing radially, whereas the RV is sort of squeezing from the base up. And so we can measure movement of the RV from the sort of base to top by measuring TAPSE. TAPSE is a quantitative value that corresponds nicely to RV systolic function. It's got high inter-observer reliability. So if Cyrus and I both measure it, we should get similar numbers pretty reliably. And you can use it pretty well as a discriminant function. So if you have a TAPSE less than 17, that's abnormal. And if you have a TAPSE less than 15, that's pretty clearly associated with increased mortality in PE. You want to tell us about some of the other useful ultrasound findings we might use or see?
Yeah, yeah, I would love to, and I'm a big fan of the TAPSE as well. I use that not infrequently in the ICU, but like you said, there are some other things we can do. So we can do Doppler imaging of the basolateral free wall of the RV, or also referred to as an S prime, and that should be greater than 10 centimeters per second in regards to velocity. You could also do an assessment looking for longitudinal strain of the RV free wall, so you can do that ultrasonographically. And just like you can look at the LV OTVTI, you can look at an RV OTVTI and look for tricuspid valve regurgitation velocities. And we'll have a citation in regards to that that we'll include in the show notes. We fully recognize that a lot of this would be better demonstrated via imaging and video, and that's certainly something that we'd like
that's
to do
coming
in the
soon.
future. Yep.
Yeah.
So keep in mind we're working towards that. It's something we'd love to do.
And actually, one other point to emphasize real quick is just like, if you're hearing us talk about TAPSE and longitudinal strain and basolateral free wall, and your eyes are just kind of glazing over at that, remember, these are skills that not everyone is going to have, but these are things that you should be able to interpret. And so if you can get a formal echo, understand what these numbers mean. The first thing that you should flip to is the TAPSE and see what that value is. Even if you don't feel super comfortable measuring TAPSE yourself, you just haven't learned that skill yet, that's fine. But you should understand how these numbers will inform your care, even if somebody else is measuring them. It's a common language.
Beautiful. Thanks, Nick. Yeah, totally agree. Definitely you want to it's kind of the old adage of like, if you order a study, you own the study. And so if you order, an echo, it's not just a matter of like looking at the interpretation, but you should at least take a moment to look at some of the values. And in the setting of PE, we definitely care about the TAPSE, in addition to some of the other values I'd mentioned. There are a couple other things we should discuss. So one thing that you may not see, but is worth noting, is this concept of apicalization of the RV. So you can see sort of displacement of the right ventricle to where it's sitting almost in line with the LV. Typically, the RV sits a little bit higher, so to speak, than the LV, but if they're kind of side by side in line, that might be concerning for RV dysfunction bordering on RV failure. And then finally, there's this idea of McConnell's sign, which is commonly discussed. And so McConnell's sign is a distinctive echocardiographic feature of acute massive pulmonary embolism. It's defined as a regional pattern of RV dysfunction with akinesia of the mid-free wall and hypercontractility of the apical wall. So you'll see that apical hyperkinesis with relative akinesia of the mid-free wall. And that's kind
And
of
what this
another way
looks
to
like
look at it.
is kind of like that the apex is sort of bouncing. It's a very distinctive look when you see
Yep,
it, and depending on who you read, it's either pretty sensitive and pretty specific for PE, or maybe not. But it is a useful sign to recognize when you see it because it's easy to spot and it can be a useful clue.
totally agree. Nick, do you want to talk a little bit about CT angiography?
Yeah, so I think increasingly, CT pulmonary angiogram is becoming the gold standard. The days where people would get an actual like angiogram are pretty rare. Um, I think the biggest limitation of getting a CT PE protocol is concerns about contrast nephropathy. And I just, direct our listeners to our episode of Zorses and Hebrews where we talk about this. But I think the harm of contrast is usually overstated, and the harm of missing PE is often understated. And so just remember, like, if you're seriously worried about PE, that's a life or death diagnosis to make. And the harm of giving contrast to make that diagnosis is likely much smaller than the risk of missing PE.
Nick, that's a great point. And it's important, I think, for our listeners to know that if they're truly worried about a pulmonary embolism, that we can sort of deal with the aftermath, whatever aftermath that may be on the back end. We really need to get that diagnosis and make the right diagnosis promptly. So I'm glad we were able to touch on that key point. Now, not only does the CTA allow us to diagnose PE, but it also gives us a hint as to whether we're dealing with an acute or a chronic PE based upon the CT appearance. And so typically in acute PEs, we're often looking at more non-occlusive type PEs versus chronic PEs that are more occlusive. And you can also see on imaging that a chronic PE will manifest some intimal irregularities or vascular calcification and possibly collateralization as well. And so that's another important thing to consider. And then the other point that we've alluded to a few times now is this idea of clot burden. And so, of course, the CT can allow us to assess that. It can also allow us to assess whether there's evidence of acute RV strain or pulmonary hypertension, secondary to the physiologic effects of the clot. And so, Nick, as you mentioned, seeing that contrast into the IVC, that reflux is a huge radiographic, red flag, and it's a predictor of mortality. But then the other thing you can look at is sort of this abnormal appearance or position of the interventricular septum, and you can compare the RV and the LV. It's low-lying fruit. It's very easy for many folks to just look at those axial views and be like, oh, okay, well, it looks bigger than it should, so that's problematic. But actually, there's good data, and the specific study I found was from Kang in 2011, to where really what we should be looking at are the 3D reconstructed 4-chamber views on a CT and not just those axial views, because those are far more indicative of how worrisome the picture truly is. No pun intended. Picture truly is. But that's really going to help you more effectively allow you to predict mortality in PE patients when looking at the RV to LV ratio, again, in that 3D reconstructed view. Now that's, I don't think there's much of an argument in 2023, almost 2024 now, at least at time of recording, for CTPE versus VQ. But VQ scans still exist. And so the data for those studies, that's a nuclear medicine study. The data for those studies comes from the PIOPED study in 1990. So it's a very old study now. And the idea is that you're looking at regions of VQ mismatch. Recall that Nick had really hammered that point home of how important VQ mismatch is in these patients. And so it stands to reason that a test designed to identify VQ mismatch can be helpful in the diagnosis of PE. The problem we run into is that these studies are, well, first of all, they require certain personnel to be in the hospital. So in some institutions, they're not always available. Second, they don't give you any of the data that I just kind of alluded to that you get from a CT that's super helpful. And at least in my practice, Nick, I don't know if this happens with you, but in my practice, more often than not, the VQ is indeterminate, or the patient has other issues going on that could explain why the VQ is one way versus another. So I personally don't find them all that helpful. Nick, I don't know, what are your thoughts on that?
Yeah, I agree. I a couple points to make here. So one is, the joke is that nuclear medicine is actually pronounced unclear medicine, because whether you're talking about a VQ scan or a tagged RBC scan, often you get these indeterminate results. So that's one problem, just like you said. Another issue is that, the Piopet study from 1990 is really ancient history. I mean, whenever people talk about, the founders of the U.S. Constitution, blah 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 blah, and they revere these people from 200 plus years ago, I'm always like, yeah, in medicine, we think people from the 1990s were total dummies. Like, how could they possibly do it this way? So it's just a funny area where medicine is very different. But I think, you will often see VQ scan as an answer choice on a multiple choice exam. And it might even be the right one on a shelf exam or something. And I'm sorry if it is. But it is almost never the right choice when you're actually taking care of sick patients, because it's almost never going to be immediately available. It's almost never going to definitively answer the question. And it's probably not that much better than the alternative, right? I mean, giving contrast really isn't that bad. And giving 10x more radiation, in the form of a VQ scan, much slower and not getting an answer, doesn't really seem like it's a great fix.
Yeah, so yeah, absolutely not the preferred study anymore for the vast majority of cases, given the lack of data that you truly derive and the likelihood that you're going to get an indeterminate study, and then frankly, now that we're in you know 2023, 2024, and we've been using low osmolar contrast for many years, that concern of contrast induced nephropathy is really something that I don't think we need to pay much lip service to anymore, particularly in cases of PE. um and I know, Nick, I know that you would agree with that, as you sort of
Yep.
outlined. So
I think we've probably beat up on VQ scan enough and praised
I
CT
think
scan
so.
enough for this episode.
Yeah, I think
Ne-
so. I think so.
Next, we should probably talk about a very cool physiologic parameter, which is your PaCO2, your arterial CO2 content, and your end-tidal CO2. And this is a great physiologic clue about what's going on, because it really tells us about dead space. So recall that your typical person might have a PA, an arterial CO2 of about 40, and an end-tidal CO2 of maybe 38 or so. That's normal. And the reason why they're not exactly the same is because normally there's a little bit of anatomic and physiologic dead space. So their exhaled CO2 is a little bit less than their arterial CO2. But if you see that this difference between PaCO2 and tidal CO2 rises, if it's greater than 5, and especially if it's much greater than 5, that's a really useful clue that there may be a regional perfusion deficit, aka increased dead space. Um, and it can tell you, it can also tell you about how well the heart is functioning. If somebody's got cardiogenic shock and their cardiac output is low, they're not going to be able to effectively pump CO2 to the lungs. So you'll also see a low end tidal CO2 from that. And that can be a really useful clue, whether you're resuscitating somebody or whether you're caring for somebody with PE and you see that their end tidal CO2 is dropping. That can be a really dire clue that their RV is failing.
Yeah, that's an excellent discussion of that difference, Nick. I think it's an important tool for our listeners to know about and to use. And so really, just to sort of summarize, a peripheral blood sample in a case like this, when compared to that end tidal CO2, you should see a larger delta. You would expect to see a larger delta, greater than that 5 number that you mentioned, indicative of that increase in dead space. And the bigger that is, the more, I almost think of it as being, the bigger it is, the more worried I might be that there's more going on in this patient than perhaps I initially thought. And so it can kind of, another way of putting it is, as the delta there can shed some light, if you will, on the extent to which the pulmonary vasculature is compromised.
Exactly. And then, yeah, one other point I just thought of to mention, which is that you don't have to poke somebody in the artery to measure their CO2, right? Your PV CO2, your venous CO2, is going to closely approximate your PA CO2. So even just a peripheral blood draw, comparing that CO2 to your exhaled or end tidal CO2 will give you a very useful physiologic clue. So make sure to use that data if you've gotten any kind of blood gas. And with that, we've come to the episode where we like to say thanks. Thanks to all the people who have left us reviews, comments, or given us a shout out on social media. We listen to you. We really appreciate your kind words and suggestions. We're actually working on some episodes based on what the audience has suggested, so thank you. If you enjoyed our show, if you're enjoying our show, be sure to subscribe, give us a like. Please leave us a 5-star review on your favorite podcast app. This helps more people find the show. And finally, talk to us on social media. Tweet or X us at CritCareTime, or individually at Nick M. Mark or at Askins_Razor. You can also follow us on Threads, Instagram, every other conceivable social media platform. And also be sure to check out the website and YouTube channel for more.
We'd also like to take this opportunity to thank our sponsor, C-Star Medical. So we are fortunate and grateful that this episode and all episodes of Critical Care Time Season 1 are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, and that's www.seastarmedical.com to learn more.
Grudgingly, I suppose we should take a moment to let you all know that we're not the only show in town when it comes to PE. Our friends over at the Curbsiders have some great PE content related primarily to outpatient or med-surg PE patients. And Josh Farkas's Internet Book of Critical Care has got a great collection of PE resources there as well. We will link to that on our website. Before we go, we should say a quick thanks to all the members of our podcast team, to Kurt Belknap for our music, and our production team over at Podpaste, who are awesome. They fixed a lot of mistakes in this episode and others. You guys are great. Finally, the podcast and all related media, including video, animations, infographics, and the audio itself, are property of Critical Care Time. You can share our content. We just ask that you say the source where you got it from.
Yeah, absolutely. And I guess finally, the views expressed within this podcast and any associated media do not necessarily reflect the views of our employers. All references to patients or encounters have been modified to be HIPAA compliant, and thus any similarities to real-world cases are purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. As Nick said, this is a two-parter. We hope you'll listen to part 2. We're super excited about that, and we are very happy to be here for you. Again, I am Dr. Cyrus Askins. So long and take care.
And I'm Dr. Nick Mark. See you guys in part 2.